So that is the end of my section, so I'm very excited. Ruth gave a bit more of a formal introduction, but I'm very excited to now introduce Lori Beyer, who is going to talk about creating cultures of trauma-informed care within organizations. And as Ruth said, she's had lots of wonderful experience working with organizations, and we hope to utilize her expertise as she works with us over the upcoming years. So welcome, Lori.
Thank you, Holly, and thank you everyone for being here. I'm very excited to be here and to talk to you about trauma-informed care and the importance of trauma-informed care. I just want to remind you again, please take care of yourselves. I sometimes give examples. They're not meant to upset or distress you, but I know that sometimes they do. And so it's always important for us to focus on trauma-informed care and self-care and vicarious traumatization. So please put that into action. I'd like to tell you a little bit about who we are at Community Connections. We are a community mental health center located in inner city Washington, D.C. We serve around 3,000 adults who have serious mental health issues. Many of them also, about 80%, have substance addiction. Some of them are court involved. We do have a relationship with the D.C. courts, and so they are sometimes court ordered into services. Unfortunately, Washington, D.C. in the United States has the highest rate of HIV infection in the United States, so we have a number of our clients who are also HIV positive. We also serve around 800 children and adolescents in our children and adolescents program. Sometimes we're serving adults in the adult side and their children in the children's side of the program. I want to tell you how we came to be involved in the work of trauma-informed care. In 1998, we developed an intervention at Community Connections called TREM, Trauma Recovery and Empowerment. And it's one of about 3 interventions that are used around the United States especially, but in other places too, also in Canada, to treat trauma and abuse. This is our women's intervention. We also have a men's and adolescent girls and an adolescent boys intervention. What we recognized as we were implementing this, what we would consider a trauma-specific intervention, is that it's hard to do trauma-specific care if you're not doing it in a trauma-informed environment. That you can do really great work when you're treating the trauma and abuse, but if you're doing it in an environment that isn't trauma-informed, you could actually re-traumatize the very people who are going to an individual session. I know that for some of you, you're doing TFCBT, trauma-focused cognitive behavioral therapy. So you could be doing great work with that trauma survivor, with their families and so on, but if the system isn't trauma-informed, we could actually re-traumatize them. And that's when Dr. Harris and Dr. Fallett, our CEO and Director of Research, wrote this manual on using trauma theory, and also we developed Creating Cultures of Trauma-Informed Care. And that's why I'm here. It's a model for a protocol for being able to help agencies and organizations to become more trauma-informed, a blueprint, how that might be possible to do that. And so what I do now is do a lot of consulting to agencies and organizations across the states and in Canada. And thank you again for having me here. I want to go through the 5 core principles of trauma-informed care and why we believe that these are so important, why we need to start here. And the first one is safety. That the patients, the clients that you're treating, first and foremost, when they come in, they need to feel safe. And why is that important to a trauma survivor? The experience of trauma and abuse is one where you never feel safe. You know, perpetrators don't give their victims a schedule, that I'm going to perpetrate you on Tuesdays and Fridays. Rather, they never know when it's going to happen. Some survivors, some people who've experienced trauma and abuse will talk about, it's as if I'm walking on eggshells, I'm walking over quicksand. I never quite know when it's going to happen to me again. When if I say the wrong thing, if I'm going to get a beating, if I'm going to be emotionally abused, sexually abused, whatever it is. That's why we believe believe that safety is primary, that when patients and clients come in to see you, if we cannot guarantee their emotional and physical safety, that then treatment is really not going to be able to happen. The next one is trustworthiness. We used to think that most, especially sexual assault, was the back alley rape by a stranger. Is that really who does most sexual assault? No, it isn't, is it? Who is it? Unfortunately, it's often someone in the family. For girls, it's almost always someone in the family. For boys, it's not necessarily someone in the family. But for boys, it might be a coach, a teacher, the weird neighbor down the street. It might be a minister or a priest. But it was always, often, whether it was a girl or a boy, it was someone they told they could what? Trust. And yet, was that person trustworthy? No, that was the person that hurt them. Now they're left not knowing, who can I trust? And so I think that all of our services are generally based on that idea that they will come in and trust us. We're the good guys, right? You know, that we wouldn't be doing this work and we wouldn't be doing human services work if we didn't care about the people that we were serving. And so we often assume that they will trust us. And yet for trauma survivors, that is one of the hardest things that they do. Being able to trust, and especially people in authority, because they were generally abused by someone who, again, was in an authority position. You know, sometimes parents said, you know, that's great that Roger sometimes tells a story, my colleague Roger Fallett, about being asked in high school by the youth minister at his church to go on a camping trip. And it was a reward for the boys who were showing the most leadership in the youth group. And yet on that trip, Roger wasn't the one who was abused, but that youth minister abused one of those 3 boys. And again, his parents trusted that youth minister. They were proud that Roger was chosen. And yet what that leaves that person who's experienced a trauma is then questioning, who can I trust? And also choice. Obviously, perpetrators take away that person who they have perpetrated on any sense of choice, any power and control. That's why it's so important that we give that choice back to them. Collaboration, to me, collaboration is taking choice up a notch. How do we help trauma survivors? How do we help someone who has experienced trauma to be able to feel like they have a seat at the table, that my opinion matters? And I think that you all have already started doing that with the patient and family-centered care model. But again, that nice overlap with trauma-informed care. How do we continue to collaborate and to help them? And that gets us into empowerment. That what we know about trauma and abuse is that it's incredibly disempowering, that perpetrator takes away your voice. Many trauma survivors, I can remember a man in one of the groups that I led, he talked about, I never knew what the right answer was when I was growing up. Was I supposed to say yes or no? So he said, I learned to say no with my body and yes with my mouth, hoping that my perpetrator would hear the answer that they wanted to hear. So he gave out mixed messages, and he basically learned to not say anything that might get him hurt. So now, how do we help people who have experienced trauma to gain that voice back, to feel like they are the people who are driving their lives? We also believe skill building is important, that oftentimes they learned skills. They learned the skills that they needed to. They adapted to their environment. They found that resiliency that they had to do. But often those adaptations and those coping skills now are no longer helping them. So how can we also work to build those skills? And so wanting to really focus on these 5 core principles as a way of structuring how do we move ahead with trauma-informed care. Now, in order to do trauma-informed care, we really believe that this is a culture shift, a systems change. And we believe for this to happen, we're asking all of you, and especially all of you at the IWK, to look at all aspects of program activities. How do you greet someone? How do you do an intake? How do you go about asking them questions about their medical history and so on? The setting, is it a warm and welcoming setting? What kind of relationships are you forming with the people that you're serving, but also relationships with each other, because they're also looking to see, do you work well with each other? You know, is this an area where there's a lot of tension, or do they see coworkers who generally enjoy each other and are working as a team? And what kind of atmosphere is there? I want to tell you about an organization in Washington, D.C. It was a transitional housing program for homeless women. And for a number of years, when I was doing direct care, I would refer some of the women that I worked to this organization. When you walked in the door of the organization, immediately, the receptionist desk was a little bit to the right, but immediately when you walked in, there was a wall there. And it said at the top, their wall of fame. And what it was is on that wall, they had a staff person, and every time one of the women in the program would accomplish something, whether it was, Tracy, great job on the job interview that you went on yesterday, or maybe it was, Allison, you know, congratulations on your 1 month of sobriety, or maybe one of the women got custody of her daughter back, and they would have a sign congratulating them, and the entire wall was covered with these signs. And that was the first thing you saw that when you walked in. How do you think people felt? And the women that I brought to the program, how do you think they felt? Do you think they felt uplifted and that this is a program about women who are making it, about women who can set goals for themselves and achieve them? And then what was also cool is that when you went to the receptionist desk and around the corner, I recognized that the wall was about an inch thick, because what they had done was it was like wallpaper, and they kept putting those signs up. And you got the enormity of the goals that were accomplished. So what kind of atmosphere do people feel when they walk in to, you know, whether it's your section of work, whether it's the main entrance at the IWK, maybe you're a community partner. What atmosphere do they see right away when they walk in? And does that help them to feel safe and that they can trust you and so on? And how do we set that up? Trauma-informed care also involves all groups. We do not believe that this is an initiative that can be done top down. You can't do it just from a management level. That you really have to involve all groups of people, administrators, supervisors, direct care staff, and obviously the people that you're serving, getting them all to the table. I also want to encourage all of you, know who the people are who are working on trauma-informed care. We want this process to be as transparent as possible so that they are telling you what are some of the changes we're thinking of making, and you are telling them, I don't think that that's a good idea, or I think you should work on this. So that the feedback is going back and forth, and that you know what's going on. Again, that old saying, information is power. Share the power with each other. Share that information. And hopefully that you will step up and know what's going on. Take an interest in the trauma-informed care team and the movement and the changes that they're trying to make. And it also makes trauma-informed care into the new routine. We all have routines at work, right? We've done things the same way over and over and again. What we would like is for that routine to involve trauma-informed care and to become so seamless in what you do that you do it without even having to think about it, because it is a part of your protocol. It is a part of how you care for the individuals, the clients, and the patients and their families that you're seeing. We also believe that in order to do trauma-informed care, there needs to be a shift in our understanding and our practice. That first we need to think differently before we act differently, and then when we act differently, we see why this makes a difference, that we see better outcomes, and that we want to continue this process. I want to give you an example. Roger Fallon and I visited a program, and it was an inpatient psychiatric unit for adolescents. And one of the managers who was showing us around, they told us that they used to have a practice on this unit. And I know I saw the Guerin Center yesterday, and it's wonderful. So very different practice from what you would see facility over at the IWK. But what it was is they had a sleeping bag, and they had somehow attached straps to the sleeping bag and closures to it. And if an adolescent on the unit got out of control, they would restrain the adolescent, take them down to the ground. They would then put them into the sleeping bag, zip it up, and then they would take the straps and they would tighten the straps. Are any of you having a reaction as I tell you about that? Yes. What do you think the adolescent was feeling? Freaked out. Powerless. Don't you think they were probably crying out, saying, let me out of here, don't do this to me, and so on? Well, a licensing organization came in, heard about this sleeping bag, and said, no. You cannot use this sleeping bag. This absolutely has to go. This is not good patient care. Right thing to do, right? But what the manager told me was that the staff was really upset because they believed that one of their best tools had been taken away from them. That they said all you had to do was threaten an adolescent or say to another adolescent, do you want to have happen to you what happened to Daryl last week? Keep doing that and we'll do it to you. My point here is, did they ever think differently? I don't think they did, that the staff didn't get it. And if we don't think differently, why would we ever act differently? And if we don't start acting differently and seeing, does this make a difference, giving trauma-informed care a chance, then how will we see if it makes a difference, if we see better outcomes, better patient, client, family engagement? And then that will clarify, okay, this is why we're doing it. This is why trauma-informed care makes a difference. And then so I want us to recognize, I'm really glad you all are here today because the first thing is thinking differently. But we can't stop at thinking differently. It has to go into how we act, and then when we start seeing those changes, reinforcing, clarifying, so that we continue to do that. So I just want to talk for a minute about trauma-informed versus trauma-specific. A trauma-specific intervention would be, as I mentioned, the TREM intervention, TFCBT, DBT, dialectical behavioral therapy. I would guess some of you do individual therapy and are working with trauma survivors. Trauma-specific treatment is when you are treating the trauma and abuse in the individual who it has happened to. Trauma-informed is changing a system, a culture, to take into account knowledge about trauma, the prevalence, the impact, how do people recover, to make the services that we're providing more hospitable and engaging. Obviously, none of us want to re-victimize. We don't want to harm the very people that we're treating, and yet sometimes we are inadvertently re-victimizing individuals. And so recognizing and being open to learning a new process, a new way of doing it. You know, possibly you've drawn blood from someone in the same way for many years. But what we might ask you in trauma-informed care is to give them a greater explanation about why you're doing it, what is going to happen. Someone in a medical setting once told us, they told me that this prick might hurt a little, but they said it after it was done, and also it hurt more than just a little, it hurt a lot. And so for them, that cut down on trustworthiness. So how could we do that differently in order to give them the information beforehand, and also to give them information accurately, you know, in regard to how much something or procedure might hurt, and so on. Then being able to facilitate that healing, the recovery, and the empowerment, and also emphasizing collaboration throughout the system. You know, it's great to have community partners here and to recognize that we're not just talking about the IWK, but also how can we impact services all around Halifax and also in the province to make, you know, really starting to make this entire community trauma-informed and having it start here. And that's what we're trying to do. And I think that's really exciting. So why are we talking about trauma-informed care? Hopefully I'm talking a bit to the choir here, that you're already there, that you agree with this. But what we know, and Holly showed you some of those slides, you know, we used to think that trauma was a rare occurrence. Now, unfortunately, what we're finding out is that it's not rare, it's pervasive. The impact is broad and diverse. It doesn't just impact them in one area of their life, but it's deep and life-shaping. Most trauma survivors will tell you there was my life before the trauma and abuse happened to me, and there's my life after it happened to me. What we also know is that it's often self-perpetuating. Some of us might have heard of the expression, hurt people, what? Hurt people. And I want to qualify that. Sometimes hurt people hurt other people. I don't want to give you the impression that all trauma survivors, that all people who have experienced trauma do that. But sometimes it happens. Did any of you hear about a year ago there was a football player in the United States, Adrian Peterson? He plays for the Minnesota Vikings. And he was arrested on child abuse charges. He was arrested for having abused his 4-year-old son. And when he was arrested and the police asked him about it, what he told them for the explanation is that what he had done to his son was use a switch on his back. And his explanation for it was, that's what my parents did to me, that's what I did to my son. I don't know this for sure, but I would hazard a guess that that's what his grandparents did to his parents. And so recognizing that often abuse and trauma is intergenerational. It goes from one generation to another. And so I think what we're also talking about is breaking that cycle. How can we help people in order to be able to learn skills, to be able to parent differently, to be able to break that cycle of trauma and abuse? It also impacts the way people approach services. Again, can I trust you? You're an authority figure. Do I feel safe here? And so on. And recognizing that sometimes our service system has been re-traumatizing, that people have been re-traumatized by going into, I can think of it, an instance, taking someone to a food stamp office. And the way that she was treated when she was there, she left in tears telling me she never wanted to go back. It didn't matter how many food stamps, what benefits they gave her. It wasn't worth the humiliating experience that she experienced there. And what we also know is that we as staff members are deeply affected by systemic stressors, that our jobs can have that component of burnout and vicarious traumatization, and we are impacted by them just as the people that we're serving. So that's why it's so important. So is trauma-informed care a fad? I was presenting and we were going around the room, people were introducing themselves, and one man said to us very boldly, I'm here today to find out the latest thing the government is shoving down our throats. I've lived through a lot of other initiatives and I'll live through this one too. So I don't know if we have any of that sentiment here, but basically what was the man saying to us? He was saying, is it the flavor of the month? Is it here today, gone tomorrow? If many of you have been at your jobs for several years, I bet you can all think of, I can think of initiatives that I was trained on 5 years ago that we no longer do. Now, I can't tell you if trauma-informed care is a fad. I don't have a crystal ball. What I can tell you is that it's getting bigger, not smaller. That it went from, I think, a regional issue to a national issue and now to an international issue. And so to explain some of this, in the state, SAMHSA is the Substance Abuse Mental Health Services Administration. It's hard in the United States to get a grant from SAMHSA if you're not proving that you're doing something about trauma-informed care. NASHBIT is in the States is a national organization of state mental health program directors. Again, a major initiative on their part. And really looking at it being included in many organizational plans. And so I think that a big foundation in the United States is the Robert Wood Johnson Foundation. They just let out 14 grants to communities to be able to help those communities become more trauma-informed. So this is really, I think, cutting-edge work, but it's also where our field is going. This is the standard of care. This next slide, I think it's simple, but in its simplicity, I think it's very profound. That what we have been doing for far too long is we have been trying to treat issues around the edge. And I also think that some things here that we're missing on this slide would be medical conditions and also education. And thinking that if we helped individuals who are having difficulties with mental health, substance abuse, medical conditions, and so on, and that we could help them, that was our goal, that's all we needed to look at, without ever looking at their experiences of violence and trauma. And I think now what what we're coming to understand is that it is so integral to their lives and their experience. It impacts every one of those other experiences in their lives. And also recognizing that often you might be treating individuals who have medical complaints that are really rooted in their trauma and abuse. Bessel van der Kolk, who has written a lot about trauma and abuse, has written a book recently, The Body Remembers What the Mind Forgets. So really trying to look at how many, of the medical issues that you're also treating might have their roots in trauma and abuse. We know trauma survivors turn to substance use. They develop mental health issues, anxiety, especially and depression, become homeless, running away from homes where they are not protected, where they do not feel safe. And then the arrows go back and forth, because what we know is that it often causes re-traumatization, that they experience more trauma and abuse. And certainly many people who have experienced trauma also talk about being in jail and prison and how re-traumatizing that can be, but also the violence within those institutions and how that impacts their lives. So really recognizing how central this is to their lives, and that we can't deal with any other issue unless we're also willing to look at the trauma and abuse. So what I wanted to do next was kind of look at traditionally how we've understood trauma, the person who's experienced it, how we deliver services, and the service relationship. And then how would we like it to change in a trauma-informed environment? So originally how we understood trauma was really using PTSD, post-traumatic stress disorder, as the model. Now where did they come up with the guidelines and the criteria for post-traumatic stress disorder? Who are they looking at? Veterans, right? Soldiers coming back from war. And so it was really seen as a discrete event. You went to war, you experienced this. It was seen as predictable. You will either develop it within 6 months or you won't. The course is probably about 18 months long, as if it would magically appear and disappear in those guidelines. I think what we want to do in a trauma-informed system is understanding that for many of the trauma survivors that we all treat, they're not going to necessarily show the symptoms and behaviors outlined for PTSD. The hypervigilance, the exaggerated startle response, and so on. Rather, what many of the trauma survivors we're working with will show us generalized anxiety, generalized depression, increased rates of substance abuse, somatic complaints, emotional dysregulation, and so on. So we would like you all to think about a definition or more be a diagnosis such as complex trauma, where we're taking into account that the impact of trauma is seen in multiple areas of their lives, that repeated trauma often is that core life event, around which every other thing in their life has then developed. And it becomes that complex pattern of actions and reactions. This is how I reacted during my trauma and abuse, and I'm continuing to use that coping strategy now. And understanding often problematic behaviors, and sometimes we label them dysfunctional behaviors, as that person who's experienced trauma, it is their attempt to cope. And they are coping in the best way that they know how. So many of you have probably heard of the Asus study. This was done in California by the Centers for Disease Control and also Kaiser Permanente. And Kaiser Permanente in the States is a managed healthcare company. They're huge in California. I think this is kind of interesting. The principal investigator in the ACE study, his name is Dr. Vincent Folletti. And Folletti at the time was running a weight loss clinic for Kaiser. There was a woman coming into the weight loss clinic doing really well, and then she stopped showing up. When they called her to find out, why aren't you coming in anymore, she said, because I'm losing too much weight and people are noticing me. What do you think her issue was in the past? Sexual abuse trauma. And when she was abused, she was thin and she was skinny and attractive, and she was afraid that now that she was losing weight and people were noticing her, what was she afraid of? It's going to happen to me again. And she said, it's not worth it. That got Folletti thinking Okay, how many other people are we treating that have issues of trauma and abuse? They asked over 17,000 Kaiser patients 10 questions. Were you physically abused as a child, emotionally abused, sexually abused? Did you have a parent who was incarcerated, a parent who was mentally ill, a parent who was substance addicted? Were you physically neglected? Were you emotionally neglected? Did you have a parent die before the age of 18? Were your parents separated, never married, or divorced to the extent that you didn't have a relationship with one of them? Then they wanted to see how many of those 17,000 Kaiser patients reported at least one adverse childhood experience. And over 12,000 of them reported at least one. So it's a huge study. Then they wanted to see, does it make a difference if you had, say, 0 childhood experiences and 4? And what do you think? Did it make a difference? It was massive. The difference was at a 4 on the ACE scale, you are 1,350 times more likely to be an IV drug user. If your ACE score goes up to a 6, you're then 4,500 times more likely. Do you remember the video that Holly showed you about resilience? You know, one of the things that they believe is that children are resilient, right? That bad things can happen to a child and they can come back. But what happens when the hits keep on coming? Is that child necessarily able to come back from that? And also, when you think about a child in their life, who is supposed to support them when bad things happen? Their caregiver, right? But what happens if the caregiver is also the one that is hurting them, making it that much more difficult for them to experience the resiliency and to be able to come back from those incredibly damaging experiences? So in this pyramid, we're looking at the adverse childhood experiences leading to disrupted neurodevelopment. We know that if you do a PET scan of a child's brain who has experienced trauma and abuse and someone who hasn't, you will see deficits in the amygdala and the hippocampus, oftentimes, and sometimes incredible deficits that they have not developed as well neurologically, leading to social, emotional, and cognitive impairment, then to the adoption of health risk behaviors. What are we talking about here? Drugs, alcohol, unsafe sex practices, undereating, overeating, often the overeating leading to COPD, diabetes, other health conditions. And then the next one, the orange one, is disease, disability, and social problems, and then early death. And they correlated that trauma and abuse can have the impact on a person's life, leading to a 9-year shorter lifespan. So pretty significant. What's also important about this study is that in terms of an epidemiological study, they have not been able to look at any other factor. You can't isolate gender or race or socioeconomic income and be able to predict adult outcomes the way trauma and abuse does. This is the seminal event that will happen in people's lives that will determine the course of their life more than any other factor that we have been able to look at. And yet, it has been a factor that we haven't been addressing. And so recognizing how important this central experience in their childhood is to all of their future development. So, traditionally, how have we looked at understanding the individual who's experienced trauma? Oftentimes, every one of our separate service system has seen the individual differently. If they come into a health center, their main concern is a medical one. A mental health center, their medical issue. A substance abuse treatment facility, it's their substance abuse. And often that the problem is understood independent of the context, not knowing exactly what has happened to them. And the problem and symptoms are often seen as synonymous, that this is the only thing wrong with you, this is what we're addressing. Sometimes we even come to call the person, by their diagnosis, that they are the person, the depressed person, the person with, this illness or that condition. And what we want to recognize is that's only part of who they are. and then often given either too little or too much responsibility for what's going on. What are we trying to do in a trauma-informed system of care? Here, we would like to take an integrated whole person approach, recognizing that we can't just look at one of those areas, but rather we have a responsibility to understand the person in the context of their lives. That's why I like the logo and the posters so much for trauma-informed care that the IWK has come up with, that your experiences matter. And understanding that symptoms are not just problems, they're not just dysfunctional behaviors, but may have been attempts to cope. That what we know is that drugs and alcohol, as Folletti said, they weren't, for the trauma survivor, the problem, they were the solution. And then adequate appropriation of responsibility. What we also want to understand is traditionally how we've looked at services, that oftentimes our primary goal was stability, the absence of symptoms, and what we have often done is seen services as reactive rather than proactive services. And that service time limits were economically driven, we decided. What are we trying to do in a trauma-informed system? Rather, we're going to have goals of growth, empowerment, resilience. And look at prevention. How can we prevent this from happening? And also asking them, how many services do you need? Traditionally, how have we understood the service relationship? And oftentimes, I think that we've seen the patient or the client as a passive recipient, that we are the people with the degrees, with the knowledge and information. We've taken for granted that they'll feel safe with us and trust us. And also, it's often been very hierarchical, that we decide, make the decisions, we are the people, with the stethoscope and so on, and that we know what's best for you. What are we trying to do in a trauma-informed system of care? That recognizing that both the patient, the client, and the service provider both have a unique perspective. And how can we draw that out? How can we make sure that they have a choice in their system of care and that their safety has to be guaranteed? And trust will not be given to us. Rather, we have to earn it over a period of time. And also that the relationships have to involve that collaboration. So as you all engage in this trauma-informed care process, we're going to ask you to look at how can you look at service level changes, but also system level changes. And there are some slides coming up that explain this a little bit more in detail. And we're also going to ask you to identify formal and informal ways that you do things. A formal way might be a form that is filled out, but the informal is how do you explain it? How do you give them information about it? And are we going to give them choices about you can fill it all out now, you can do some of it now, some of it later, and how could we do that informally? And then asking each key questions about how we do it, prioritizing goals for change. Sometimes change is easy, sometimes it's much harder. And we sometimes think about how can we get the low-hanging fruit, those things that are easy at first, and then looking at what are we going to change? Who's the person responsible? And how long do they have? So that we're very specific about what we're trying to get done. So I wanted to look with you a little bit more closely at these 5 core principles, starting with safety. And how can we maximize safety? How can we give as much choice as possible? Choices such as, where would you like to sit in the office? Do you want the door opened or closed? That might seem contraindicated to ask them if they want the door open. But again, for some trauma survivors, bad things happened behind closed doors. So how can we give them as much choice as possible? What kind of lighting? Can we have fluorescent lighting, but also possibly softer lighting? For some trauma survivors, part of their trauma is the somatic complaints, having migraines. The fluorescent lighting can add to that. And then emotional safety. Do they know that they can talk about anything with you? So this is a quote from the newspaper. If people don't feel safe here, nothing else is going to happen. Where do you think the here was? Could it be at a hospital? Could it be at a school, at a daycare center? The real issue here is that the here could be anywhere, right? This happened to be at a shopping mall, and they believed that there was gang activity at the shopping mall, and one of the store owners said if people don't feel safe, nothing else is going to happen. But I think it applies to all of us, doesn't it? Now, where do you think this sign was? It was at a substance abuse center. And we saw it, and we said to them, for a lot of trauma survivors, denial is what got them through. Maybe you could have a sign that said recovery starts here. Well, they weren't willing to change it to that, but they did change it to welcome. Optimism lives here. We believe in kids. A school? Would it surprise you to hear this was at a juvenile justice center for boys? Roger Fallett and I visited 2 in the state of Missouri. And I tell you, leaving the one that had this sign up, I had tears in my eyes. And not tears of sadness, but of joy. It was such an incredible center. And they had a program called Trauma Echoes, where they helped the boys to understand how the trauma had echoed through their lives. But signs can't create an atmosphere, but they can reflect it. And I want to tell you, this sign reflected the atmosphere there. You are entering a safe and special place. This was actually at a school. And would it surprise you to hear that kids in inner city situations, 30% of them qualify for the diagnosis of PTSD? And so I think saying to those kids, you're entering a safe and special place. From wherever you are, enter and be welcome. And this was at a homelessness shelter, letting them know wherever, whatever you've done, the drugs, the alcohol, whatever it is, the homelessness, the person you used to be, enter here and you are welcome. What about trustworthiness? How can we maximize trustworthiness? If we're going to say we're going to meet with someone at 1 o'clock, do we? Do we let them know boundaries, what they're responsible for, what we're responsible for? Oftentimes, when they grew up with trauma and abuse, there were no boundaries, and so they didn't know what that was. And now it's important that we model those boundaries. I was getting my kitchen remodeled, and when I was looking for a remodeler, I came across this on a website. And many of these trust points, I think, are really good, but could we focus at the bottom, too? We tell you what we're going to do before we do it. Do I have that right? Yeah. And then we tell it straight. We listen carefully, we tell it straight, and we can keep our promises. Thank you. And I think that those 2 lines really bring up the core of trustworthiness. And I just want to say to you, if the kitchen remodelers can do it, can we do it? Can we tell it straight, keep our promises, and so on? And I think it's a good thing for us to remember. Choice, how can we maximize choice? Recognizing for trauma survivors, small choices can have a big impact. So whether the lighting where they can sit, if they have a choice, if the appointment is done today or tomorrow. Do you want it in the morning or afternoon? What works best for you? And so on. This used to be an ounce of prevention is worth a pound of cure. And now what we're saying is that choice in routine practice, in crisis, and that small choices can have big consequences. Collaboration, how can we give them a seat at the table? How can we make sure that we are hearing their voices and that they have a say in not only their care, but how their care is delivered, in the decisions that are made that impact all of the patients and clients you serve, whether it's through a client or a patient advisory board, focus groups, surveys. How can we increase that collaboration? And what we want to stop doing is doing things to people or for people, but rather recognize that we are walking the walk, we're doing it with them. And then we also wanted to look at empowerment. Again, helping them to get their voices back. So how can we do that in routine service delivery to make sure that we're constantly asking them what's best for you? What has been your experience? Letting them know that their experiences and who they are, that it matters. And it's going to make a huge difference in their treatment outcomes. I recently went into Starbucks, and have you ever gone into a place, whether it was Tim Hortons, Starbucks, wherever it was, and you walk out with a receipt that's a mile long? What do they want you to do? a survey, right? And they want you to often go online. This one promised that I would be entered in a drawing for a $1,000 Starbucks gift card. I thought that sounded pretty good, so I decided to do it. Now, unfortunately, I didn't win the $1,000 Starbucks gift card, but I got kind of a good story out of it, so I'll tell you that story. The survey started much as you would expect. Was your drink prepared properly? Did anyone greet me by name? I was happy to say I go in there sometimes, but not so often that they actually know my name by now, so I was happy about that. Was it clean? Yes, it was. Did I find everything I needed? The last question on the survey, was your visit to Starbucks today, and what do you think the Starbucks standard was? Was it good? Was it satisfactory? Maybe a little higher than that. Excellent? Yes? Their question, or their word in that blank was your visit to Starbucks today uplifting? Well, the caffeine was a little. But what would you use the word uplifting for? What kind of experience? Maybe a spiritual experience? But not necessarily a visit to a coffee shop, right? But I want to ask you, if Starbucks standard is uplifting, what is our standard? Are we going for satisfactory? Would we be satisfied with, I think, even excellent? But what would it be like to ask the patients and the clients and the families that you serve, was your visit today uplifting? And looking at, if that is Starbucks standard, what is ours? And what are we happy with? We also, a part of trauma-informed care for us is that we deeply believe you cannot expect staff to be able to provide safety, trustworthiness, choice, collaboration, and empowerment if the staff is not experiencing it themselves. And so we have an entire focus on how do we take care of staff. And we're going to spend some time after break looking at your experience and what it's like for you as staff members. We're also going to ask, when you do trauma-informed care, to look at 5 other areas. One of those are to review formal policies. You know, as Holly mentioned, what we're always looking for is reducing restraint and seclusion. Those, I think we can all understand, are re-traumatizing. But there can be other policies that might be re-traumatizing. And how can we eliminate those? We're also going to ask you to look at trauma screening, assessment, and service planning. And I know that for the IWK, that's something that is on your trauma-informed care plan. It's not going to happen today or tomorrow, but having that standardized screening and assessment is important. And then what I would say to all of you, don't just ask the questions, but also have resources, whether you're doing it yourself or referring them out. How can they get resources for receiving trauma-specific services? Also, administrative-wide support. It's hard to do a trauma-informed care initiative if administration is not in favor of it. And so administration who's willing to put it into the strategic plan, who's willing to allow staff some time and money and space to be able to do trauma-informed care, to be able to have 4 sessions for you all to come to and to have a webinar so that you can learn about trauma-informed care. I think that that's very important. We're also going to ask about training and education. It's hard for staff to be trauma-informed if they don't know what trauma-informed care is. And so how do we educate? But also our programs generally have turnover. So how do we educate new employees? And also human resources. When we hire people, do we ask about trauma? Have you ever worked with a trauma survivor? And I'm not saying that you shouldn't hire them if they haven't, but are they willing to consider that as part of someone's life experience and how it would impact their treatment outcomes? Possibly also adding it to job descriptions and yearly evaluations, that is part of what is expected of employees. And in conclusion, what I'd like you to take away from this is that all of us, in order to be trauma-informed, we need to know about the impact of trauma, the prevalence, and how survivors or people who have experienced trauma, how do they recover from those experiences? And also, remember about the fundamental shifts in thinking, that if we don't think differently, are we ever going to act differently? That sleeping bag story, if they never understood how re-traumatizing it was, then they wouldn't understand why they stopped doing it. And so then when we start doing things differently, then we see the outcome and why it matters. And also recognizing that trauma-informed care means that enhanced collaboration, so that we're working well with each other, so that the families, patients, and clients we serve are getting trauma-informed care throughout the province, throughout Halifax, and that trauma-informed care becomes the standard of care. Thank you, everyone.